I think today we will discuss how you want to manage asthma, the chronic asthma, how you want to treat them properly lah, so that they don't come with exacerbation again in the futures. Okay, first thing first, you need to know how bad is the asthma. So in a newly diagnosed patient with asthma, so you basically classify them into intermittent asthma or persistent asthma. Alright, so persistent asthma can be divided into three groups: the mild persistent, moderately persistent, or severe persistent asthma. Okay, so the difference basically severe daily daytime symptom, daily night symptom, and then have interval symptom almost every days, and then frequent exacerbation. Alright, so mild will have at least once twice exacerbation, every 3 months exacerbation kind of thing, and then weekly cough, weekly exercise into cough. Okay, then moderate will be a bit more. Okay, once you classify them into the type of persistent and intermittent, then that's how you decide whether this patient needs treatment or not. Okay, the intermittent asthma is basically have exacerbation once in a while, but not more like once a year, or maybe twice a year the maximum. If more than that, every 3 months they have exacerbation, is uncontrolled asthma, is persistent kind of asthma. Okay, the intermittent asthma should be once a year or once in 2 years time, then I would say that's intermittent asthma. Then you will not need to start MDI prophylaxis. Okay, MDI, what it means by MDI prophylaxis is basically your MDI fluticasone, MDI budesonide, which is your MDI that contains steroids. Okay, your MDI salbutamol is just a reliever. So okay, your MDI, there is two types, which is your MDI salbutamol, which is your reliever. It relieves the bronchospasm, but it doesn't do anything to the inflammation caused by the IgE mediated processes. Okay, which cause a lot of inflammation to the airway, a lot of secretion causing the symptoms. Okay, all right. So before once you decide to start the MDIs, so you need to educate the parents, educate the patient if patient is big enough. So how you educate the parent and patient is by showing them what is happening in the lungs, then why they need the treatment, and why the two MDIs is differ from each other. Okay, most of the time we use the diagram. If you have the model of airway, it's even better. You need to draw the lung. So you just draw the lungs first. Draw the trees, draw the right lung, draw the left lung. Okay, so what happened in asthma is basically at the airway. So you just take the cross section of your airway and draw. Okay, so draw the normal airway with the wall. Airway wall is normal, not swollen, then a bit of secretion which is normal to have inside. Then draw the abdomen in the patient with asthma. Okay, draw a bit thicker. Okay, normal. Then asthma patient. Okay, the wall is thick, a lot of secretion inside. Okay, right. Another thing you need to draw is when there is bronchospasm. Whatever the thing is become even smaller. Okay, bronchospasm. Alright. Okay. Alright. So what happened in the bronchospasm? The thing got very become even narrower. So very difficult for air to go in and out. You start your MDI salbutamol on neck to relieve the symptoms from here to here. Okay, so it bronchodilate. Okay, all right. So this process will happen a few days for it to completely recover. Once the infection settles, the bronchospasm will get better by itself. Okay, however, it doesn't do anything to the wall, so that's why you need your MDI, fluticasone, MDI, budesonide. Okay, all right. So when you give it to this thing, so it helps change the inflamed airways to the normal airways. Okay, however, the process take years or months to happen. Okay, so that's why you need to emphasize on compliance, and then you show the parents the difference of the two medication. The salbutamol is as a reliever, and this one is your preventer. Okay, so basically it prevent the exacerbation of asthma. The reliever relieve the bronchospasm. Okay, so I expect the medical student, even the houseman, to explain, give asthma education like this by showing the diagram. What's the difference? What is happening in the airway? What is the difference between two medication, and why one need to take every day, which is your fluticasone need to take every day for months, for years before it works. Okay, so and then the thing, once you already educate the parents, and then you need to next thing to teach them the techniques. Once you educate patient with the diagram, you make them understand what's the difference between the two MDIs, the blue color one, the orange or the brown color one. So the difference between the two, then it's easier to explain, and then it's easier for them to comply, because they understand. But most of the parents, they will stop using it once the patient gets better, patient don't have exacerbation, so they will stop the MDI prophylaxis, the fluticasone or budesonide themselves. So when you educate them properly, they understand that they cannot stop it. We have to continue until at least once year no exacerbation. Then we can start reducing the dose, and then continue follow up some more. Then if no more exacerbation after reduction of the dose, then you can off it. Okay, so the dose, how you start, you can refer to the PITS protocol. If mild persistent, just start the low dose or moderate dose. For me, it don't really matter either you start 1 puff BD or 2 puff BD, but those with severe for sure need the higher treatment dose, which is your 2 puff BD. The severe, those with very severe asthma attack requiring NIV intubation, requiring IV magnesium sulfate, IV isobutamol, those are categorized as severe exacerbation, which is need very at least moderate dose of prophylaxis or high dose of prophylaxis. Okay, so and then how you step up the treatment, and then how you step down the treatment when during the follow up you ask about the interval symptoms. If the interval symptom is well controlled, no nighttime cough, no daytime cough, no exercise induced cough, no cold induced cough, no exacerbation for the past 6 months or 1 year, you may consider continuing or step down the dose. All right. Okay, and then if you step down the dose, the patient remains well, no exacerbation, the interval symptom is still the same, no interval symptoms, you can may step down further or may off them. If the interval symptoms still present, still persistent, you just continue first, and then you might want to ask about compliance, whether the patient comply to the medication or not. Okay, all right. Okay, so I think before we move on further on the follow-up thing, during the newly diagnosed asthma education, other than educating the need for the medication, other than you also need to teach the parent the technique of Aerochamber technique. Okay, so I prefer for all children to use the Aerochamber technique, to use Aerochamber for the MDI, because children usually have difficulties to use the MDI using direct technique, because direct technique need a lot of coordination, and proper technique to inhale it properly. Even adult has problem, so I don't expect children will do better compared to adult. Okay, even 10 years old, 11 years old, first time diagnosed, we still advise parents to buy the Aerochamber. Okay, once they are quite big already, then we may change to the metered dose to the powder form of inhaler. Okay, alright. So Aerochamber technique, other than the technique how they administer the thing, you need to advise parent how to store the Aerochamber and how to wash it. Okay, so we just store at the normal temperature in a small container to keep it dry, and then we will need to wash it at least once a week. How you wash it also important, because the inner part of the Aerochamber, they have some static charges that help push the medication towards the patient. Okay, so it's very important to advise the parent not to wipes the inside, because it may cause a scratch. This scratch also affect the static charges inside the Aerochamber, will affect the deliveries of the medication to the patient. Okay, alright. On top of it, other than asthma education, we also need to advise parent on asthma action plan. Okay, asthma action plan is basically the papers that have instruction for the parent on how much to give the MDI to the patient during the exacerbation, or when patient is planned to be discharged. So you give that asthma action plan, how to continue giving MDI at home until patient has completely recovered. Alright, so let's say patient already on 4 hourly MDI salbutamol and MDI fluticasone 1 puff BD. So it's time for them to go back. Patient already no more on oxygen, and then patient already been taught all the technique of Aerochamber. Parent has been educated, and then they are quite comfortable using the Aerochamber themselves. Then that's the time to go back to discharge. So we give them this asthma action plan for them to continue the MDI every 4 hours for the next 1-2 days. How many puff also we will write down in the plan. Give it, for example, 6 puff every 4 hours for 2 days. So after 2 days, you step down the dose to 4 puff 6 hourly for 2 days. Then after that, we reduce to 2 puff 8 hourly until the symptom completely resolved. Then we off them. Okay, in the meantime, we also ask the parent to continue with the MDI fluticasone or MDI budesonide. And then the instruction in the asthma action plan is to not to stop the MDI budesonide, just to continue patient during patient's well. If patient is unwell, they still need to give the MDI. Okay, so one more thing, when we use for when patient is unwell, we also have the asthma action plan also stated if patient started having symptom of URTI, start runny nose, even and start coughing. Even patient don't have rapid breathing yet, no shortness of breath yet, the asthma action plan will tell the parent they can start giving the MDI salbutamol as a method to prevent the bronchospasm. So they can start with small dose like 2 puff 8 hourly, then they can step up if the symptom worsen. Okay, if the symptom static and then patient get better, they may stop the MDI salbutamol. Okay, alright. One more thing, in asthma action plan, there is a thing, there is instruction for emergencies. If patient having shortness of breath, and then the shortness of breath is quite severe, there is instruction to use the MDI salbutamol to give high dose like 6 puff or 12 puff, depends on the weight, every 20 minutes, while telling them to go to the nearest hospital. And then while on the way, they can give the puff 6 puff or 12 puff, it depends on the weight, and then every 20 minutes until they reach the hospital. Okay, this is part of the thing mentioned in asthma action plan. Okay, so when patient already been discharged at home, then they come back for follow-up. So the doctors who see the patient will need to ask about the interval symptom. basically to determine the control. If patient still have some night cough, some cold-induced cough, so this is the history that suggests to you that the symptom is still not well controlled. But also, we also ask how frequent they use their MDI at home if patient unwell, and any exacerbation mean patient having shortness of breath. Those are history that we take when patient come for follow-up. During follow-up, we advise the parent and patient to bring their MDI, the Aerochamber as well, so that we can assess the technique, because technique is very important, because if they give the medication wrong technique, then it's considered like a patient not being given any medication at all. Alright, we also want to basically assess how the condition of the Aerochamber. If the Aerochamber is in a bad condition, that's another reason for medication not being delivered properly. So we will advise the parent to change the Aerochamber. Okay, we ask about how they wash, how they store. If the inside has been wiped and then scratched a lot, so that's another reason for them to change the Aerochamber. Okay, next we ask about how frequent they miss the school because of exacerbation, and we also ask about any other factors that might affect the control. Okay, for example, if there is any cat at home, which is your pet, and then if there is a lot of dusty area, like the stuff that may store some dust, like the carpet, how frequent they wash it or not, then this one could contribute to the cough, and could contribute to the patient not having control asthma. Okay, on top of it, don't forget to ask about anyone smoking at home. Okay, so if patient got smoking at home, and then the problem with smokes is very very difficult to control. If they say this, the father said or whoever said they smoke outside, it's considered still smoking, because when they smoke, their breath will smell a lot like smoke. The chemicals, nicotine, will still stain the mouth, stain the lips, stain the hand, so stain the baju as well. If they smoke outside, if once they finish, they go back inside and they touch their kids who has asthma, this may cause the coughing, they may cause the symptom not fully controlled. Okay, so the best advice for the parent with asthmatic child is to totally stop smoking. So we can advise parent, we may offer them to quit smoking by referring them to the quit smoking clinic. I think a lot of hospital and clinic also in KK will have quit smoking clinic to help the person who want to quit smoking. They will provide counseling and then certain medication like nicotine patch to help them deal with the craving of the nicotine once they stop smoking. Okay. Alright, so once you follow them up, usually the first follow up of asthma in the newly diagnosed patient, we see back after 2 months and 3 months. We want to see how they do at home and how's the technique, as I said earlier. If patient is well, you can see a bit longer, like 4 months. Most of the time asthma we see every 4 months. Okay, so once patient have no exacerbation at all for 1 year, then compliance to the MDI, to the MDI fluticasone, and then that's the time to step down. But if the patient continuously have interval symptoms and then symptom is not well controlled, then you can step up the dose. Okay, if the compliance is good. If compliance is not good, most of the time we don't really change the dose, we just advise the compliance. Okay, how you step up? You can step up the dose to be higher, like from 1 puff BD of fluticasone become 2 puff BD, or if budesonide from 1 puff BD become 2 puff BD as well. Okay, the next step up is basically you can step up to serotype. Serotype is basically combination of your salmeterol, the long-acting beta-2 agonist, which is your salmeterol, combined with fluticasone. There is 2 doses, is 25, 125, and 50 to 50. Okay, so this LABA or long-acting helps with the bronchodilate, so causing less bronchospasm, so causing less coughing. The fluticasone will deal with the inflammation part. Okay, so if patient on Sartan still not fully controlled, the next option is to either combine with LTRA, leukotriene antagonist, which is your montelukast. Okay, montelukast is one of anti-inflammatory medication to help reduce the IgE level and reduce the inflammation level in the lung tissue, in the airways. So we help with the asthma control symptom. So if Sartan still not well controlled, if montelukast still not well controlled, given that compliance is very good, then the next step up is basically to use certain drugs like immunomodulator, but this one is fall under pediatric respi category. Okay. So one more thing to do is basically don't forget to do peak flow when patient already stable after the acute attack. So you can do the peak flow to measure the reversibility after you give the MDI salbutamol. So if there is 20% increment of the peak flow before and after your MDI salbutamol, that indicates reversibility of the airway spasm. So that helps you give you a clue diagnosis. This could be asthma. If there is no reversibility, then it could be something else. Another test that may help to look for reversibility lah in a patient who are poorly controlled asthma, or it might not be asthma at all. It could be your lung function test. One of the thing they do is basically they give you salbutamol and then they measure your lung function, whether the reading there is increment or not after you give the salbutamol. That indicates reversibility. If the reading is the same pre and post salbutamol, so that indicates there's not much reversibility, then it indicates this could be something else. It's not asthma. Okay. So if the patient who are poorly controlled, you want to question the diagnosis for asthma, whether this patient could be having something else. Some of the clue includes your failure to thrive. If patient having failure to thrive, that could be something else. Could be chronic suppurative lung, could be bronchiectasis, could be something more sinister like tracheoesophageal fistula. So it's very important to plot the growth chart during the admission and during the follow-up. And then another clue that this patient might not be having asthma is basically your clubbing. If patient has clubbing, it indicates something more sinister like chronic suppurative lung disease. It could be tracheoesophageal fistula as well. Okay, it could be cystic fibrosis as well. Okay, those are suppurative lung disease. All right.